Hi, everybody. This is Dr. McNamara, and we are going to be doing the communication lecture. So I'm going to just be going through the slides that you have within the Blackboard site that I posted. So sorry about that. So what happens is that communication is really, to me, a fascinating topic because it's something that happens every single day, that we do all the time, that we don't even think about that's happening. So when you look at we're going to go to the second slide, which has the foundation of everything we do. So that's the truth. It is the foundation of everything. We're constantly communicating, even when we're not talking. It's because of our nonverbal communication patterns that are happening. So it is a dynamic series of events that we're going to talk about, but the key thing is that meaning is generated from one person to another, from one person to a group. The key thing that we need to be careful for is that the error in communication is when what's transmitted and the person understands is not necessarily what you meant. So there's a big issue with communication that happens all the time. You may have remembered when you were a kid that maybe in school they do that exercise a lot of times where the first person whispers into somebody's ear, and then when they get to the end of the class, the message is very different by the time it gets to the bottom. So we're trying to prevent that by being good communicators or therapeutic communicators, as some may say. So we need to think about that and be aware of what are the influencing factors, what causes us, what influences our understanding and our communication patterns. And that's our next slide, number 3, influencing factors. One of the things is our perception. What we think is going on is going to influence how we react and what we go on with that communication. Sometimes we're off with that, and we get defensive about things because we think that we're being insulted or something in that communication pattern. Our values and our belief systems are strong influencing factors. So that is, our religious beliefs, our spiritual beliefs, our culture, our socioeconomic culture, and the influencing factors that tell us how we are to appropriately communicate with each other in different situations. A big factor too is our past experiences, and that's really, really an important thing, is that it may be that you may have seen me on this video and you decide that you really don't like me. There's something about me that you just can't put your finger on. And basically, that's often related to our past experiences, that perhaps I remind you of someone that you had a bad interaction with in the past, and therefore your mind projects those feelings onto me. Oftentimes, we're not really aware of it. So I'm not aware that I'm doing that. And I can't tell you who it is or who they remind me of, but it just tells me that something's off and that it interacts my future interactions with that person. So the purpose of these influencing factors and being aware of them is to prevent their influencing our communications with people as we go forward. So we know that there are 3 elements. The research is saying there's 3 elements of communication, and it's rather simple. There's the sender, there's the message, and then there's the receiver. So the key elements are really simple. However, the key point or the on target point is that we always have to make sure that the receiver received what we wanted them to and how we wanted it to say, and that the message in that translation didn't get changed in some way so that they walk away with the wrong message. So it seems simple, but it's probably the most important thing that happens during the day that causes us to have conflict with other people. We're going to go to slide 5, which talks about the mode of communications. So it's very simple too, verbal and nonverbal. There's 2 modes of communication, the 2 primary modes. We know that when we look at research, the true meaning is more in the nonverbal cues than the verbal. So they say about like 90%, 85 to 95% of the true communication is in the nonverbal clues. And you've seen that where people say something with their words, but their tonation, their mannerisms or intonation get you to have a different meaning for that. And I remember somebody that I used to have a relationship with that they were really good at that nonverbal thing. So they would say things to me and the words and everything were fine. But then when I walked away and I thought about the whole context of everything, I would always think about what was the true meaning of that. And some people, I think, do that really well as they send that message that there's this underlying message they want you to get. But so when we look at the verbal communications, this is slide 6. That's the words that we use, the vocabulary, and then how we say them, intonation, the tone of our voice, and then the timing and relevance. Is it the right time to say something? Is it the most relevant time? And so there's a lot of research on timing and relevance. It's very political, like in getting points across at certain times. So I am going to post a video, YouTube video on it that I thought was really interesting about the importance of timing and relevance. But, you know, in our everyday communications, it's also, is this the right time to say something to a person or is it not? So, you know, some people may say it's like changing the subject when you're in the wrong time and relevance. So suppose you're talking to me about the death of your father, and then I suddenly say, "Oh, I watched this really good movie last night," and I take it in a different direction. Usually, you can see it does turn people off. You'll see that on their face because it looks like you're not listening, is what it communicates. The nonverbal clues on slide 7 are the ones that are where the true meaning is. And there's a number of those. There's appearance, there's posture and gait, facial expressions, hand gestures, touch, and space and territoriality. So when we look at appearance, appearance is really important because that's how people make decisions about us. And in the healthcare, there's been a lot of research on that, about how we dress and the projection and what that projects. So if I am coming to work today as a clinician and my uniform or my clothes that I'm wearing, the scrubs, are all wrinkled and my hair is not combed and I look just disheveled, it does project to patients that we don't really know what we're talking about or what we're doing, and they lack confidence in us. And so you may debate and say, well, but that's not really true. And it's not true. That does not appear, your appearance does not say what you actually know, but that is reality. It's the reality of what the world sees. So we have to think about that. So there's been a lot of studies of the importance of uniforms and looking together. And so you'll find that when you work in some organizations, they'll have really strict uniform policies. To the point of like 1 earring per ear, 1 ring per finger. Some of that, the rings are infection control stuff, but no tattoos showing. Some people have, you know, directions about how your hair must be done if it's longer than your collar. And these are all things to control the appearance, to project that we know what we're doing. And so you may say, you know, it's not reality, but the issue is that if you are a patient in the hospital and I come in to do a potentially painful thing, maybe like a catheterization where they're going to put a catheter in your urinary area, and you're not put to sleep for that. But if I come in and I am really dressed up, you know, like in a suit and a lab coat, and I look like I present myself well, or if I look like I just rolled out of bed and my hair's not combed, and they say, who do you want to do it to you? The studies predominantly pick the person that looks more together because they project that. So it's something that we really need to think about. And a lot of the professions really put a lot of clout in that appearance to really dress like a professional and project that image that is out there. Posture and gait's really important. That's, you know, how you sit, how you hold yourself, and how you walk. That projects, a lot of it does, I think, is project if you really care or not. Some people say, well, she really doesn't want to be here. And it's mostly because the way that someone's sitting in a chair and the way they're walking, how they manage themselves. And hold on a second. Gosh, I'm trying to like. Okay, I'm sorry I got interrupted, but so that really does project things. Our facial expressions really do project a lot. And oftentimes we're not aware of what our face does when we're in certain situations. So we really need to think about that in communication with patients. And it also should be on here too is eye contact. Eye contact really does show in our culture that you are interested in what you're doing. Now we have to remember that in some cultures, eye contact is a no-no. So and that it is culturally defined where they won't look at us, and sometimes we don't trust that. So we have to be aware of those influencing factors that when we see someone who avoids eye contact, if it's culturally defined, like in some Asian cultures. Hand gestures is culturally defined. There's some cultures that are more expressive in their hand gestures. And then a nonverbal communication tool is touch. It shows that we care and we're compassionate, especially in our culture. But today it's been, with sexual harassment issues, it is a touchy subject, I guess, no pun intended, but about what it is. But I think they've done a lot of studies that showed that touch is needed in human beings, and that if you look back at the time when we had AIDS, HIV, and AIDS within the early 80s when it first came out, they didn't know what that was. We didn't have a diagnosis. We didn't know what the disease was. So, but we did know that 100% of the people that were diagnosed were dead within the first year. And so it was really a horrible process that we were going through at that time. And we didn't know how it was transmitted. We didn't know that it was bloodborne. We thought it might be respiratory. So we had to wear double gloves. We had to wear moon suits. They were actually suits. We had hoods on with ventilators in the back so that we could go into the room because they didn't know how this was going to be transmitted. And some of those patients then never had another human touch. They felt touched through gloves, but it's not the same thing. Families had to use the same garb. And really, it displaced people from the environment. Because even though you're there, you're displaced because of these barriers that you have. Sort of even like with the internet, with our pandemic. Although we're seeing people in video, it's not the same as being there in person with them. So we know that does impact. And in healthcare, touch, I think people really value that. But so what I do is I'm a touchy person, being a nurse. But so what I would say is if I'm going into the room, I will sometimes say to the patient, do you mind if I hold your hand? Touch is important to me. If I offend you, let me know, just so that I do that. Because if I'm going into a patient's room and I'm talking to them, usually I'll grab their hand to touch them. It also tells me assessment about them. It shows me if they're diaphoretic. It also, if they're touched, their hand grasp is strong or weak. It tells me stuff about their physical condition. So that really is helpful to me too. Space and territoriality is that issue with when people are too close. So we all have a space difference that's comfortable for us. And when somebody comes too close, we feel that automatically, and you automatically want to push back. So in that space and territoriality issue, it's culturally defined. And you may find that there's some cultures, like the Greek culture, in my context, they're a little too close to me. They come into my personal space and it makes me uncomfortable more. Whereas there may be other cultures that are further away. So we have to think about that within the context of, our communications. So it is something that we need to think about within the context of our caregiving. Now, it is interesting to me that patients that are on psychotropic drugs, it affects that issue of space and territoriality for them. So you may find out that if you have a patient with a psychiatric condition, like schizophrenia, for instance, and they're on certain medications, the medication affects that space perception that we have, and they get a little too close. Like they come up really close to you because it takes away that ability. So just to remember that. When we think about touch too, when we talk about culture, we also know that like Orthodox Jewish patients, they're in the religion, there's the issue of cleanliness and non-cleanliness. So if a woman is menstruating, she's considered not clean. And that becomes an issue because typically, if you're a nurse taking care of an Orthodox Jewish male, and you come into the room and you try to shake their hand, they don't shake your hand, they'll pull their hand back. And you might find that like offensive or might insult you, but the issue is that it's based on their religion. And that's because they don't know who's menstruating, who's not. So they don't touch women for fear that they're going to touch her when she's in a state of uncleanliness. And that's because of their religious practices. So you may see that that's an issue. I know that for me, when I'm doing graduation and I shake hands, I have to be careful because if it's an Orthodox Jewish person, the girls won't reach out to shake my hand or hold their hands back because of that cultural belief system. Okay, so now we're going to go into the slide 8, which is the communication essentials. So when we're trying to communicate, especially to patients, what are we trying to do? We're going to try to be accurate and simplistic. So we're not going to use medical terms, right? Medical terms can be misunderstood, and patients, a lot of studies have shown that they don't want to appear not intelligent, and so they will say yes, like they understand when they really don't. So I've seen patients coming to with a physician, the physician come in and say to them, we found that you do have a malignant melanoma and you have a prognosis of about 6 months or less, and we're going to do palliation. And then they walk out, and the patient acts like they know that. And when you talk to them, you say, okay, what did the doctor say? And they'll say, part of it is what they want to hear too, but some of it, they don't understand the words. And what they'll say is, oh, I have this condition and it's going to go away in 6 months. And they get a whole different perception of it. So once, the physician has told them the news, then other healthcare providers can reinforce that. So I'm not going to turn around and say, no, that's absolutely not what he said. I'm going to try to communicate with them so that they can receive the message and say, well, malignant melanoma is, and try to explain it to them, in a compassionate way. We want to be concise and short, because if we go on forever and ever, they lose the message. So they don't see the concise message that we're trying to give to them. So we don't want to bury it in all this other communication stuff. We know that our communication patterns are confidential. So when we're in context of healthcare, we are held to confidentiality rules with our patients. And I think sometimes that helps them communicate more openly to us sometimes. But the key thing of what we're doing is trying to have listening skills. So listening is the key thing, because none of us have, the answers to anything. So a patient may say to me, what would you do if you were in my shoes? And my response is, I'm not in your shoes, but maybe what we can do is we can think about it together. And so maybe if you're thinking about a choice, I may say to them, let's think about what your options are. And then let's look at the positive and negatives for each one, and you can think through it. And I let them think through it. I don't do it for them. So and then to listen. I think that if you look in your life, the person that you call the most to talk to is the person that listens to you, not the person who's constantly giving you advice. So I know that I'm of Irish background, and I have a pretty large family. I have 6 brothers and sisters, and they all communicate differently. And I know that my one sister is the person that I usually call to, and that's because she listens and she doesn't really give me advice. So she'll listen to me, and I can tell she's listening by her active engagement, which we'll talk about. And then I have another sister who I can't even get through something because she'll stop me to say, listen, this is what you need to do. Or why did you ever do such a thing? She's more like that. So that's not the person that I kind of go to. So I also think about what happens when we're listening is that it takes concentration. We need to think about what they're saying because our mind wanders. And so you may be, while they're talking to you, if they're talking and talking, I may be thinking about what I'm going to buy at the store, what I'm going to do. And then if I come back to you and say, what did they say? You won't remember because you weren't paying attention to them. So it really does take an effort to do that. So we're going to talk about what those listening skills are and how that works. So if you go to slide 9, when our key thing in listening is really to communicate concern and acceptance. It's not for me to agree or disagree. That's not what my role is in healthcare, to agree or disagree with anyone. What I do is I need to show that I'm concerned and that my role is to accept them for where they are. So I may be, I'm a Christian background and I may have certain belief systems that are core to me. However, that doesn't matter in my communication patterns with my patients. It's not for me to agree or disagree, but to accept them for who they are. So when I was working in hospice, I was a manager, and I would have some nurses come to me and they say they wanted a job in hospice. And a couple have come up to me and said, because they were Christian and they really wanted to help people come to Christ when they were in the dying process. That's not our job. That's a different aspect of chaplaincy that's not for us to do. So I even though I may be Christian, my patient really doesn't know that, and it doesn't matter to them, and it doesn't matter how I take care of them or a person who's not a Christian. It should be all the same. And so now in end-of-life care, they may have religious issues that are inherent with dying, but I refer that to someone who is specialized in that area, like the hospice chaplain. So really, it's just allowing them to talk so that they can release negative feelings. So we know that stress causes all kinds of health problems. And what they found is that even by talking, it really decreases the stress level. So how many times have you had something that happened to you really bad, and just by talking about it, you feel a little lighter at the end of it? Nothing changed. You didn't change what happened. You didn't respond. All you're doing is releasing the negative feelings. It helps us deal with the issues and decreases our strength, decreases the stress. So that's what the point is, especially in healthcare when people are suffering, is to listen and hear them for what they want to express. And I also think too is that I have my own lived experience, you have your own lived experience, and the patient has their own lived experience. We therefore don't know what causes them to come to the decisions that they make. So for instance, maybe I'm taking care of a patient who's being abused by her husband, and she's really being abused by them, and she continues to stay with him. That's a hard thing for me to deal with, but I don't know what her life has been like that got her to this point. I need to make sure that she understands the options that are available to her. But I can't, when she doesn't choose the option, as a clinician, I can't say, well, because you didn't do this, I don't really want to hear about it anymore. That's what my role is, to actively listen. Silence is also very therapeutic, and you kind of know when when you don't know someone, silence sometimes is really uncomfortable. Think about if you've ever been on a blind date, and what happens is when it's really quiet, you start to get uncomfortable and you try to think about things to say. So in the context of therapeutic communication, that's not a bad thing because it causes people to communicate things and to start talking. So I know in taking care of my patients that are terminally ill, sometimes, they don't want to talk. And sometimes I've made a commitment that I'm going to be there, and I have 15 minutes to sit with them. And so I will say to them, I have 15 minutes to sit with you. If you want to talk, that's fine. If you don't, that's fine too. I'm just going to sit here. And what happens is notoriously they'll start to say things, and the more they talk, their feelings will come out and we can help them. Acknowledgements are important too. And that's like saying, shaking your head, yes, looking at the patient, it communicates that you're hearing. And when somebody doesn't do that to you, you recognize right away. You're like, you think about to the person, are you really listening when they're not doing those things? Because it appears like they're not paying attention to what you're saying. Now, we also have listening faults, and that's where we've made a mistake in our communication patterns, which changes the meaning. So adding is when I add things into it based on my background or who I am. So for instance, when we talk about the example where one person says something to a child in a class, and then it goes through the whole class, and at the end it's a different message, that's an example of adding, or also deleting, because they could delete something that's important. But adding is when I add to that situation. So for instance, we had a hospice patient once that was dying. Of course, he's like 70 years old, and he's a male. And when the nurse went to visit him, he was talking to her about the number of affairs that he had on his wife, and he was still married. He had cheated a lot during their life, and he was talking to her about that. The nurse had just gotten divorced from her husband, who was had been cheated on. She was cheated on. Her husband had cheated on her. So it brought up, I guess, personal feelings for her. So when she came back to the office, she said, I really think that Mr. Jones needs a counselor, because he's really having a hard time dealing with his guilt feelings because he cheated on his wife. So we got a counselor. The counselor went in, and then when the counselor came back, he said, nah, that's really not the truth. He did cheat, but he's actually proud of it, and he was really an acceptant of what he did. And so that's an example of adding, because the nurse added to the incident based on feelings that she was having and what she thought the patient was communicating. So it goes back to that first slide again, one of those first slides, where you have to make sure that the message is what the receiver received. So to make sure, you would say, let me make sure, do I really understand what you're saying? And this is what I thought you said, to make sure. Rushing, if we're rushing people and they don't have time to produce their thoughts together, then they're not going to be able to communicate what is really happening there. And unfortunately, in the hospital settings, that usually happens. And then analyzing. So we're not psychiatrists. We're not psychologists. We're trained most clinicians are trained in therapeutic communication about what we should say or shouldn't say, but we're not really there to analyze. That's not for us. So we should try to refrain from doing that, because that will change some of that communication pattern. So this brings us to slide 11, under-listening. So I'm communicating with a patient, and examples of under-listening is when I undershoot the item. So maybe the patient was talking to me about something, and I was, and it had relevance to the patient, but I didn't put relevance on it. So I thought it really didn't mean anything, so I leave it out. And that's omitting. I leave something out. I know that, one of the things that we do in the hospital in nursing is that we give report at the end of each shift. And so when you give a report, you tell what happened to the patient during the shift. And I can't tell how many times that you make notes and everything, but then I would omit something. I would forget something that I wanted to say. And then I usually work the evening. So I would go home and I would wake up in the middle of the night at 3 and think, oh my gosh, I forgot to say that, and call back into the hospital. So sometimes we know that omitting something can change the whole meaning of the communication pattern. Lagging is when you're sitting and you're talking to somebody and you're lagging behind. So meaning that I keep taking them back, like I keep rewinding. So maybe we're talking about vacation, and then they go on to talk about Christmas. And then I say, wait a second, and I take them back to the conversation that we were on before when they were talking about their vacation. So instead of being on time, I'm thinking and I'm behind in processing it. That's what lagging is. Parroting is when I keep repeating it back. So that may be, I say, and actually when I was in nursing school in the 80s, we were taught to parrot. They said that it was therapeutic, but I think once somebody does it to you, you can realize that it's not therapeutic. It's kind of annoying. So if I was parroting, if the patient said to me, I feel like I might get sick, I would say, you feel like you might get sick? And maybe they come back and say, yeah, I think I might vomit. And I would be like, you might vomit. So I take it back and I repeat the exact words back to them over and over again as a way to guide their conversation. I think that you see that doesn't kind of work. It kind of annoys you when that happens. So we try not to parrot situations. So there's also things that will cause the stop sign to go up, which stops people from talking to us. So when we think about talking to our friends, sometimes these things will stop the communication. One thing is giving an opinion. For us, that kind of, in healthcare, it kind of non-evaluates where the patient's at. And it's not for us to give an opinion. We haven't lived their life. We don't know what their experience is. So our opinion does not matter. So the other thing is false reassurance. And that means that I'm going to say, oh, no, you're going to be fine. I don't know that they're going to be fine. So if the patient is terminally ill and they say to me, I think I'm dying, and I say, oh, you're going to be fine, they're not going to be fine. And what that does is it stops them from talking because they feel like I'm not validating what they do. So those conversations are hard. So suppose the person is terminally ill and they say to me, I think I'm dying. And what I might say to them is, what makes you think you're dying? And that helps them talk more to give me symptoms of issues. Now, if they ask me directly, am I dying? And as long as the doctor has shared that information with them, then I'm able to turn around and say, yes, you're dying. But it really would depend on the context of the conversation if I would do that. Being defensive is a thing that is a big roadblock to communication. And I think that with students sometimes is that once they become defensive, they stop listening and they don't value what we're saying to them. So a lot of that is how we give messages. If we give messages that say you messages, often people will respond defensively. So if your kids, if they did something and you go and say, you left the refrigerator open, the response always typically is, no, I didn't. They become defensive with it. So it's the context and how you do it. What we're doing in communication, especially when we're talking about leadership communication, is we're trying to break down barriers to get people to change behaviors. And if they can't listen and hear, then they're not going to be able to change behaviors with us. So the next one is approval, disapproval. It's not for me to give my approval or disapproval. My opinion doesn't matter, so I shouldn't do that to my patients. A lot of the books say that we shouldn't ask why. So I wouldn't say, why did you do that? I may get to that answer by asking it in a different way, but the word why is supposed to attach bad connotations to it. Mommy asked why, and it makes people feel guilty. Why would you do that? That's the intonation thing there added to that. So we should try not to ask why. We ask for explanations instead. Arguing is a roadblock to communication. So what happens is when you argue, you have a winner and a loser. One person walks away as feeling like a winner and one walks away as a loser. And in reality, you both lose. So you try to get to a win-win situation where you both compromise. But when you have a winner and a loser, we don't win. It ruins that relationship. It doesn't work. So we never, ever argue with patients. That's not what our role is, and we're not there for that. Now, what happens, though, is that you may have patients that are argumentative, but then you have to learn how to deal with that and to diffuse that argumentative. And sometimes that may be that, what happens is when and I give you all these death issues because that's my background, but when part of dealing with death and dying is that we become angry. And so patients lash out at us sometimes or at their families as clinicians. We need to remember where that's coming from. So it's a behavior that has a meaning, and I'm not going to respond to that. So I'm not going to enter into an argument. I'm going to try to diffuse the situation. And I need to remember that it's not because they're a nasty person. It's probably the context of the disease that's causing them to act out in a different way. And you know what? That asking for explanations there, that's incorrect, actually. The second one, it's not a roadblock. And then the last one is changing the subject. So changing the subject is a roadblock because it talks like you're not listening and you really aren't paying attention. So that's really not therapeutic to do. Now, there may be sometimes in reality when I have to do that. So maybe I'm talking to a patient and maybe I've had a recent loss of my father and the patient's talking about something that brings that up. And what I'm trying, and I can't deal with it. So I change the subject to get them off the topic. And then what I would do is talk to a colleague to see if they could go back and talk to the patient about it because I wasn't able to go there. So sometimes you have to do it to protect yourself. So our relationships, these communications that we do, and our helping relationships with patients is really to give them a social interaction, to be genuine. When we're not genuine, you know somebody who's fake right away when you talk to them. So it's that genuineness. We also need to be empathetic as opposed to sympathetic. And you may see this question somewhere again. What is empathy versus sympathy? Sympathy is when I feel sorry for someone, and that's not effective. Empathy is the ability to relate to what they're saying. I can actually maybe feel what they're saying, but then I can release myself from it. So when I become sympathetic, I'm over entrenched with them. When I'm empathetic, I can go back to living. So for instance, when I was first taking care of hospice patients, maybe my daughter had a birthday, and when I came home, it was a birthday party, but I couldn't relax. I couldn't interact with the birthday party. I went to bed, or I went in a different room because I was so sad about my patients. That's sympathy. Empathy would be the ability to be there, be with my patients when they're there, but when I leave it, I can leave that there and I can go about caring for them. So that's what empathy is. I saw once before is that, I saw a drawing where they showed a big ditch. And in an empathy relationship, you're actually at the top of the ditch, the patient's in the ditch, and you're trying to help them out of the ditch. In a sympathetic relationship, you get in the ditch with that patient, which is not effective. I think that kind of makes it a little clearer. So, and I have to tell you, it takes time to get empathetic, and it takes skill. And I think you learn that as you mature in your careers, the ability to be there and then to really be present, but then to leave it where it's at. Trust is another important thing because if patients don't trust us, they're not going to communicate with us. And so then you might say, well, how do you learn trust? Well, you learn trust by being faithful to your communications to the patient. So suppose you say, suppose somebody is thirsty and I say, let me get you a drink of water. And I go out and get the drink of water and I bring it back. Patients that I followed through has meaning to them. And that's how they learn to trust me. I also think they learn to trust you because of your interest in how you carry yourself as a person. That helps them to learn to trust us so that they can communicate, that they feel like it's a safe place. And sometimes it's safer communicating with us as strangers than it is to their own family members because they don't want to upset them. So they'll be able to say things to you that they may not have said to family because they're afraid of hurting them. But the whole thing about these relationships is that it causes us to have a therapeutic interaction. So some other things in therapeutic communications, in interactions, it's really a gift of offering ourselves to patients that helps them communicate their patterns. And through that, we focus on things. So you may say, well, I'm a sleep technologist. I don't really communicate the patient sleeping most of the time that I have it. But there is times that, I had a sleep test done and I had a really hard time sleeping. But because of the interactions I had with the sleep technologist and how comfortable she made me feel in my communication patterns, then it helped me to sleep better when I was having my test done. So there's always that issue. Open-ended questions are really good ways to communicate with people because if somebody's not opening up to you, if you say closed-ended communication patterns, you're not going to get them to open up. So a closed-ended question may be, did you have a nice day today? And they can answer yes or no. Anytime that they can answer yes or no, that's a closed-ended question. So you've had these people where they're hard to talk to and say, have you had a nice day today? Yes. And then you go to ask another question, and they tend to give you one-word answers and yes or no responses. So open-ended questions would be like, what did you do today? Because then they have to tell me what happened. So it's more effective in getting people to open up. The more they talk, the better they relax they're going to feel, and the more communication you're going to have. It's also therapeutic to focus on things. So it may be in the context of just talking to a friend that they say something, and then you might focus them back and say, what exactly did you mean with that? To try to elaborate those feelings in that area when we're trying to be good listeners. Other things that we can do is seek clarification to make sure that we understand. Giving information. So a lot of times, like even anywhere you are, based on your clinical expertise, that's when we would communicate information. So maybe we're in a situation where somebody's asking you about the safety of the COVID-19 vaccination. And maybe they're saying, I don't think that I'm going to get that vaccine because of, I don't think it's, they processed it too early. So then you can give information about, well, they went through a lot of testing, statistical analysis, and that the effectiveness of the vaccine is somewhere over 90%. So you may give information that helps them make a decision. Sharing observations is another therapeutic thing. So I've had patients where they're tapping their foot on the floor, they're shaking, and I may say to them, are you nervous? And they may say to me, no, I'm not nervous. And then sometimes I may say back to them, well, I hear you saying that you're not nervous, but what I'm seeing is that you're tapping on the floor, you're shaking your head, and that tells me that maybe you're uncomfortable. So I do the observations back to them. We talked about silence. And then if I'm in a therapeutic communication where I'm talking about a specific thing with a patient, then it may be summarizing at the end is effective. I think about that in the context if you're a medical assistant working in an office. You may say, okay, before the patient leaves, let's summarize what you did. We gave you a vaccination. You need to do this, this, and this as you follow up. And a key thing in communication is that we're not judgmental. We're not there to judge. Our judgment doesn't matter. We're facilitators. Okay, and then slide number 16. Just giving you some ideas of, to clarify, you might say, what do you mean by something, in a communication? A reflective statement where I reflect back to the patient. You said that if you were very angry, you would do this. That's how I might put that in context. Paraphrasing is I'm going to summarize, sort of like summarizing to me. I think they're the same thing as far as to me. Summarizing, you summarize the whole event, but paraphrasing, it may be just making sure I understood what happened in that communication. Number 17. So we talked about the issues between empathy and sympathy. And I also think about the importance of, we talked about the importance of associations when we talked about, in the beginning of the lecture, when we talked about your past experiences affecting your communication patterns. And then we didn't really talk about emotional involvement. So I think as clinicians, sometimes it's really hard to really displace ourselves and not get emotional. And that goes back to that empathy and that sympathy situation. But what I will say is, my father passed away a number of years ago, and the nurse cried. And that really touched me. She was emotional, but it really touched me because it showed me that she really cared, but she also was able to do her job. So the issue is when it becomes a problem is when you're so emotional that you can't function in the role that you have to do. I think what people expect from us as healthcare providers is they want genuineness from us. And so they want to know that we care and that we have some empathy for their situation. And we try to understand where they're at. And what really turns people off is when we act like we don't care. And I think that's customer service too, is because what people are expecting from us. So there are phases that you'll see in resources about the phases of a therapeutic relationship. And this actually is not so much of the, well, you could think about it in any relationship that you have with patients. Even if you were an x-ray technician, you still have this kind of process. So it could be a short-term relationship or ones that last over months, like with the therapist you would have. You have a pre-interaction stage, and that's when you find out why you're interacting with that person. Maybe you get the lab slip that they need to have blood drawn. And then there's the orientation phase when you tell the patient what's the purpose of your relationship. So in blood draw, I would take them in, say, my name is Jane or John, and I'm going to draw your blood today. That's the orientation phase. The working phase is when I actually do it. And then the termination phase is when it's over and I say, thank you for coming today. I drew your blood. You'll get results back. So that's really simplified, but that's the phase of all reactions, of all communication patterns. So within those patterns, we're going to have communication in the phases. So within the working phase, while I'm drawing the blood, the patient may be talking to me about other things. And that's where I'm going to be doing more of my communications at, my communication patterns. So it kind of just summarizes those phases. So that's the end of this lecture, the first one. I'm a little awkward with because it feels awkward to me to lecture when I can't see you guys. So if you have any questions, you have my email, smcnamara2. It has a 2 on it. There is another professor here that doesn't have the 2. So remember that it's with the 2 on it, and that way I'll get the email. Please don't email me on Blackboard because I don't check that as often. You'll get me faster there. So you may say then, what is the last thing that Dr. McNamara would say about the test that's going to be on there? So it will be questions, and it will be asking you what is the most appropriate response. And I think that sometimes is, I'll post some examples of it. What you think is the appropriate response to say to someone. So it may say today, you might have a choice where it says you're communicating with a patient, and which of the following is not the communication pattern to use. And maybe it's that I say to the patient, I was touching you and I think you're diaphoretic. Diaphoretic is a medical term, so we wouldn't use medical terms in communicating with patients. So that would be why the answer is incorrect. So to think about it in context of how you would talk to a patient. So I'm going to leave you with that, and we will be in touch. Thank you.